This short video will rapidly and precisely discuss DIC, or Disseminated Intravascular Coagulation. It will discuss the definition, etiology, pathophysiology, management and complications. DIC, or Disseminated Intravascular Coagulation, is a syndrome characterized by the systemic intravascular activation of coagulation leading to a widespread deposition of fibrin. This results in the consumption of platelets and clotting factors, leading to both thrombosis, both arterial and venous, arterial affecting the skin, CNS, respiratory, liver, renal, and limbs, and venous, i.e., deep vein thrombosis, but also bleeding. DIC disrupts the fine balance between the antifibrinolytic and fibrinolytic systems which occur in health. The epidemiology, it affects all ages, there's no sex preference, and it affects up to 1% of hospitalized patients. In sepsis, it can affect up to 30% of patients. The etiology is based on both obstetric and non-obstetric etiologies. Obstetric, for example, postpartum hemorrhage, preeclampsia leading to HELLP syndrome, amniotic fluid embolism, and also placental abruption. Non-obstetric causes include sepsis, pancreatitis, burns, trauma, liver disease, transplant rejection, significant transfusion reactions, and malignancy. With reference to coagulation in health, tissue factor is the best known primary cellular initiator of blood coagulation. The factor VII tissue factor complex activates the coagulation protease cascade, leading to fibrin deposition and activation of platelets. Excess coagulation is controlled by the use of plasmin and also natural anticoagulants, including protein C, S, and Z. Sepsis-induced DIC is due to the activation of tissue factor, both on injured endothelium cells, but also the immune cells, including monocytes and macrophages. Activation of tissue factor leads to the activation of the coagulation cascade, leading to clot formation, and thus thrombus formation. The consumption of these coagulation factors leads to a lack of coagulation factors and thus bleeding. You also get the suppression of the fibrinolytic system by the upregulation of plasminogen activator inhibitor 1. DIC is a clinical pathological diagnosis. There's usually an underlying etiology, for example, a chest infection, which is triggered to produce a more severe reaction, for example, sepsis leading to multi-organ dysfunction. Within DIC, there's usually features of bleeding and/or thrombosis. With reference to investigations, there's no one specific test for the diagnosis of DIC. However, the PT and APT are classically increased. Prolongation of these is usually in 50 to 60% of cases at some point during the course of the illness. Along with an increased PT and APTT, D-dimer may also be increased. D-dimer is a fibrin degradation product, which is a small protein fragment present in the blood after a blood clot is degraded by fibrinolysis. Due to the increased production of clots, platelets and fibrinogen will also be decreased. To aid the diagnosis, there's a range of scoring systems which can be used. The first one, the International Society of Thrombosis and Hemostasis DIC score, which is widely used for the diagnosis of overt DIC with a score greater than or equal to 5, but also the Japanese Association of Acute Medicine score, which is specifically designed for the acute onset of sepsis-induced coagulopathy. Key differential diagnosis for patients presenting with DIC will be hematological conditions including TTP, ITP, HLH, hematological malignancies, and post-transfusion purpura, in addition to other causes including drugs and alcohol, and the effects of mechanical circulatory support. In comparison to TTP, thrombotic thrombocytopenia purpura, DIC has increased levels of Adams TS13 level activity, prolongation of PT, reduced fibrinogen levels, and an increased D-dimer. The key point with management in DIC is treating the underlying pathology. If the patient is bleeding, the initial management should be based on an ABCDE approach with blood resuscitation in addition with additional agents. Classically, antifibrinolytic agents, for example tranexamic acid, are not clinically indicated in DIC due to the increased risk of thrombosis. However, other agents, including calcium and vitamin K, can be considered. Regular assessment regards the patient's volume status and coagulopathy are essential via TEG or ROTEM, whilst maintaining normal temperature, preventing acidosis by ensuring adequate oxygen delivery and volume status, whilst preventing coagulopathy. Ongoing management should be, as described, management of the underlying etiology, but also the consideration of anticoagulation, as noted as DIC is a procoagulant state and there's a risk of micro or macro thrombosis. Hematological targets for patients should be based on clinical advice from hematology, but also local and national guidelines. Classically, the targets could be as followed. The hemoglobin count should be based on the patient characteristics, which can be between 7 and 10 grams per deciliter. The platelet transfusion threshold varies. If the patient is not bleeding, a platelet count of less than 10 may be indicated for transfusion to prevent spontaneous bleeding, whilst if the patient is actively bleeding, a count of less than 50 may indicate platelet transfusion. In bleeding patients with DIC and prolongation of PT and APTT, FFP may be useful, and we could aim for a PT of less than 1.5. If the fibrinogen level is less than 150 milligrams per deciliter, FFP and possibly cryo may be indicated. The complications of DIC relate to thrombosis and bleeding. Thrombosis can affect the arterial and venous system, and therefore within the arterial system, it can affect any organ. Bleeding can occur in the respiratory tract, in the cardiovascular system, leading to, for example, a pericardial effusion, GI hemorrhage, and CNS bleeding, which can result in a range of CNS-related clinical features, but also into the skin. In critically ill patients with DIC, the 28-day mortality ranges from 20 to 50%.